surgeon. He has vast experience in reconstructive microsurgery and obstructive azoospermia and has pioneered new approaches to sperm retrieval and in non-obstructive azoospermia. He was founder president of the South Asian Society of Sexual Medicine and is a recipient of the prestigious Dr. B.C. Roy Award from the President of India for developing andrology in India. He has published and present extensively and has contributed over 20 book chapters. He is the consultant andrologist at the Lilavati Hospital and Research Center in Mumbai. He is also associate editor of our journal, Fertility and Reproduction. He is the senior advisor of the Global Andrology Forum. Please give a warm welcome to Dr. Min Cha.
Good morning, Chairman, ladies and gentlemen. It's a privilege to be here. I thank Aspire for this invitation and actually an honor to follow such a wonderful talk on what has been achieved in cryopreservation, and I'm going to touch upon some of this as we look into the future of andrology. So this is primarily a group of reproductive specialists, and you have been guilty. You've come up with ICSI, which has enabled us to treat male infertility very dramatically, but also ICSI resulted in male fertility being forgotten and pushed to the background with the famous statement by Paul Devroy, "Give me a sperm and I'll give you a baby." We kind of forgot the man behind the sperm. So today I'm trying to reclaim a position for the man in the galaxy of, or in the constellation of infertility management. And indeed, in the last few years, there has been a revival of interest in why men should be treated. So today, as we look at the past, to understand the present, to project into the future, my objective will be to try and share some of the excitement of these new developments and convey to you what you can do as clinicians and researchers in this journey. I'll be showing some equipment. I have no financial relationship with them, so I have no relevant disclosures. So there's a whole range of topics that we will touch upon. And I don't want this glimpse into the future to be purely exotic. So I'm going to also talk about some very practical, clinically relevant aspects of the future in which clinicians here and now today can get involved in the research. So let's start with something very basic, which is the semen test. In the past, we had the first 4 issues of the WHO manual of the semen testing, and the norms were based more on expert opinion. In the 5th edition, we had the unique approach of looking at the semen profiles of 1,800 men, and based on a statistical evaluation of the 5th percentile, we derived cutoffs. But in the 6th edition, the WHO manual has finally taken a very bold step to acknowledge something that as clinicians we've known and experienced for a long time. And they made this statement that we actually cannot have a reference point which will distinguish between fertile and infertile men. So though we have the 5th percentile with the whole reference range, this is now just a suggestion. We no longer can say that, oh, this man is 14 million per ml and therefore he's infertile, and this one has 18 million per ml and therefore he's fertile. So where does that take us to in the future? Actually, what this does for the clinician, even though it seems confusing, is actually liberate us. It gives us the freedom to look not just at the sperm count, but at many more factors which I'll come to thereby decide that maybe for this man, even with a count of 2.5 million, he's fertile. And maybe for this person, even though he's 20 million, maybe if we improve him towards the 50th percentile, we will increase fertility. So here is one concept that we might look at more in the future. This is just one study, time to pregnancy in 500 couples. And what the authors found is that in fact, as the sperm count increased, motility increased, the time to pregnancy shortened until we reached a certain upper threshold, which means that this threshold is closer to the 40th, 50th percentile rather than the 5th. And therefore, I think in future, we will no longer be looking at semen analysis as a fertile versus infertile distinction, but more as just a probability guide. I suspect we might even have a fertility score from 0 to 10, 0 being the azoospermic or the total teratozospermia, but 1 to 10 being based on semen parameters individually, in combination with the husband's age, wife's age, duration of infertility, all put together to thereby assess the fertility of a male. And that may in turn be linked to further research with sperm DNA fragmentation. Now, we've had 2 wonderful symposia in this very meeting on sperm DNA fragmentation, but there's still a huge amount of confusion. This study compared 50 fertile and 50 infertile men. And as you can see, for different tests, the relevant cutoff points were very different, and the sensitivity, specificity was very different. So even though we acknowledge that knowing about the DNA fragmentation of a sperm is very useful in predicting outcomes, we don't really know how to measure it. And I think near future research is going to focus on identifying which is the best test that should be used and which would be the best cutoff that should be used. Linked to this also is going to be a change in how semen testing is done. The cell phone in my pocket is far more powerful than the computers of just 20 years ago. And with the ultra-high resolution of modern cameras, we'll see many more such devices where the patient will just put a drop of semen in the little slot. The semen will spread to the examination window. He'll put his cell phone on it, and boom, he'll have an image and an analysis. And this will mean that men will be testing themselves in the comfort of their home, early diagnosis of a problem, easy follow-up, and maybe even clinicians might just have these reports being mailed to them for a follow-up of the male patients. Further, I think it's almost inevitable that we're going to go back to automatization, because as we see newer semen analysis machines using deep learning and neural networks, they are overcoming the shortcomings of the earlier huge CASA machines. These are extremely simple to use, need no calibration, are not operator dependent, and give a result within minutes. So virtually every clinic will probably wind up having these once the costing comes down. And there's an important reason why this automatization will be required. One is because there are some aspects to the semen test where manual methods are too subjective. In the 4th issue of the WHO manual, motility was distinguished as rapid progressive, slow progressive. In the 5th edition, this distinction was eliminated because the editors felt that it was too subjective a distinction and that the lab personnel were unable to make it accurately. There's a huge hue and cry about it, stating that no, knowing rapid progressive sperm is important in determining fertility, and therefore in the 6th edition, the distinction has come back. Now, if we want to make this distinction, and manually it is hard to do so, we are going to depend on automatization. Again, another parameter, morphology. We went from general morphology to strict morphology, and I think now we are in the realm of over strict morphology. This was just one study which we just published, showing that the way morphology is now assessed by most IVF clinics is so strict that it has lost its relevance. And we found an interesting analysis. If you look at the box to the right, in the top are 6 studies all using the latest strict criteria from the 5th edition, and none of them found a correlation between pregnancy rates and morphology. In the bottom box are 5 studies based on the 4th edition of the WHO manual, and all of them found a correlation between morphology and pregnancy rates, suggesting that somewhere down the line we have lost the plot. We need to redefine morphology, and perhaps that will be accurately then measured by an automatic semen analyzer. Moving on, how will medical therapy change? Yesterday we had a very interesting talk on antioxidants. The hall was filled with ART specialists all wanting to know which antioxidant to prescribe. And at the end, Professor Chris said, "I'm sorry, but we don't know whether they work, and we don't know which one is to be given." And I think the reason for that is that till now, all medical therapy, by and large, except in hypo, has been empirical. And the future of medical therapy is going to be personalized. So, as was pointed out yesterday, we know that we need physiological levels of reactive oxygen. We know that giving too much of antioxidants will shift the patient from oxidative stress to reductive stress. And yet, the universal practice today is huge quantities of antioxidants being prescribed to every infertile male. The future is probably going to have an individualized profile, use of machines, and now the latest, again, WHO manual talks of, in the advanced test, measurements of reactive oxygen species. I think very soon, in the next edition, this will move from advanced to extended or even basic testing. Because only if we profile the male completely will we be able to personalize medicine. And this will hold true in multiple areas. Here was a very interesting study showing that giving recombinant FSH would actually lower DNA fragmentation. But before you start giving it to everyone, read the whole paper. It shows that this is effective only in those men who had polymorphism of the FSH receptor. And there are a number of other such situations where having the full genomic profile of an individual male will guide us as to whether there's a genetic cause of his asthenozoospermia, or for his necrozoospermia, or for his receptor non-responsiveness. And then based on that and other profiling, the medical therapy will be far more pinpointed and accurate. So all these parameters could be considered in personalizing therapy. I wasn't going to talk about varicocele because for urologists it's common. But on Thursday in our workshop, we had a 4-hour workshop on varicocele. And the enthusiastic response that we got, especially from Claire, made me think that we need to talk about varicoceles for the future. So in the past, based on the first 4 Cochrane reviews, most ART specialists said varicocele, pooh, it doesn't matter. The latest review, however, concedes that while men with varicoceles could achieve a pregnancy without the varicocele being treated, correcting the varicocele would significantly increase the pregnancy rates. And there have been many other studies and meta-analysis and global surveys after that validating the need for varicocele therapy in some men. Additionally, studies have shown quite interestingly that even in a couple undergoing IVF, if the man has a varicocele and it is corrected and then IVF is done, the chance of conception is significantly higher. And the reason for this is also shown in another meta-analysis that showed that varicocele repair lowers on an average the DNA fragmentation by about 7, which is relevant clinically in improving the pregnancy rate. There's also evidence that men who are azoospermic, non-obstructive azoospermia, if their varicocele is corrected, either sperm will appear in the ejaculate, though it's few and transitory very often, or the sperm retrieval rate by T-say micro T-cell will increase. So, in the present, the attention has come back to varicocele, but in the process, I think a lot of ART specialists are making another error, and which is to refer all men for ultrasound to look for a varicocele. So here a little word of caution. Only clinically significant varicoceles matter. and therefore doing an ultrasound before doing a clinical examination is not valid. So I think in the future, one, we're going to have predictive models, again based on the ubiquitous AI, where we will know which men with which varicocele are likely to benefit from repair, and I hope that all male partners will be evaluated, and this has other reasons too. There's a huge amount of growing evidence that severe male infertility is significantly predictive of other health disorders. Twice risk of malignancy, cardiovascular disease, other metabolic disorders, thyroid disorders, and therefore if a man has a significant infertility problem, it warrants a medical evaluation beyond just a treatment for the infertility problem. In the future, I think we're also going to be more sensitive to the environmental factors causing infertility. Now, here we have not been lagging behind. This wonderful book, Our Stolen Future, is more than 40 years old, and it paints an amazing picture of how the human species has polluted the planet to such an extent that polar bears in the Arctic Circle have declining fertility. This followed Rachel Carson's masterpiece, The Silent Spring, and it's a really scary book to read. Now already today this awareness is there, and if you look at the internet, there are a large number of sites suggesting how EDCs are harmful and what you can do to avoid them. But I think in the future we will be going further, much more regulation to eliminate plastics, chemicals, toxins from the environment. And perhaps as clinicians, part of our profiling of infertile men will include a toxicology screen as a routine, especially when no other cause is identified. And hopefully we will also develop ways of detoxifying those where high levels of endocrine toxins have been identified as a cause of their infertility. One of the big advances in male infertility has been the advent of microsurgery. It started in 1978 with Sherman Silber's first paper, and the 80s were really the heyday of microsurgery. And I'd like to explain why this is relevant and then come back to how the reproductive specialists need to be aware of it. So if a man has a block in the epididymis, but normal sperm production in the testes, he will be azoospermic. However, this block can be bypassed by joining the vas to the epididymis. The problem is that this epididymal ductule, even when dilated, is only 1/3 of a millimeter in size. And therefore, conventionally, before microsurgery came into andrology, the only way the surgeon could do this surgery was by splitting the vas, splitting the epididymis, and suturing the vas, not to the ductule, but to the epididymal tunic. So it was actually a kind of fistula that was created, and it was hoped that sperm leaking from the cut tubule will find their way into the vas lumen. With the advent of microsurgery, it became possible to magnify this tubule 25 times, to dissect an individual tubule, to make a small opening in it, and with 10-0 or 11-0 nylon, join that sliver of the vas mucosa to the even more flimsy epididymal ductule to achieve an anastomosis with a doubling of the success rate. The tragedy was that there were very few microsurgeons and a lot of ART specialists never took it seriously. The same technology allows us to do a vasectomy reversal with more than a 90% success rate, because you can even see the capillaries in the mucosa of the vas lumen. Again, microsurgery for varicocelectomy, it becomes possible to identify and preserve the testicular artery while tying off all the veins, thereby lowering recurrence, avoiding arterial damage, and improving the chances of success after a varicocele surgery. So Aspire has had two debates, one this year and one 5 years ago, on whether a man with obstructive azoospermia is better off having reproductive microsurgery or just sperm aspiration and ART. And in the last debate in 2019, where Professor Tanaka was saying, well, ART is good, and I was saying, no, microsurgery. A month before the debate, a patient sent this email, and I'd like to read it out because it has an important message for the ART specialist. And the patient says, I was a patient of azoospermia. I met you in December. You did my VEA, vasoepididymal anastomosis, in March 2018. 6 months later, my sperm count is normal, motility is 10%. At 8 months, the motility is 15%, and my wife is normally pregnant. Now comes the main line. All the doctors in Mumbai suggested me ICSI IVF and told me VEA will not help. But you did it successfully, and I thank you from the bottom of my heart. Now, I'm not trying to gloat. Maybe a little gloating is allowed. But the message that I actually wanted to carry out here is that all too often the ART specialist just sees egg, sperm, pregnancy, and forgets that behind the sperm is a man with a heart, with an ego, with his own concerns. And while men will agree to have their sperm aspirated with needles poking in their testes, all of them, or most of them, would certainly prefer socially, emotionally, and otherwise to naturally father a child. And this is something that you should not forget in the rush to push every patient towards IVF. And now finally, the last horizon, the management of non-obstructive azoospermia. Now in the past, the only option was donor insemination or adoption. Already much has changed in the present. The advent of ICSI made it possible to take a single sperm from the testes and fertilize the egg. With that came the realization that testicular histology is not just black and white. It's not just no sperm or normal sperm. There is a middle ground where most of the testes doesn't have sperm, but there are a few sperms scattered around, and this patient is still azoospermic, though there is no obstruction, because you need a minimum amount of sperm before they can come out in the ejaculate. Thus, somewhere between 20 to 50% of men with maturation arrest, hyperspermatogenesis, Sertoli cell syndrome only, testicular atrophy, could still have some sperm in the testes which can be retrieved and used successfully for ICSI. We also know that sometimes these sperm are scattered throughout, and simple techniques to retrieve sperm might work, like the conventional biopsy. Sometimes these sperm are very focal and needs a complete exploration. And those cases are quite remarkable when you're looking at a sea of tiny atrophic tubules, and suddenly one big fat tubule pops out. And there are really no limits. This was a patient whose testes was literally the size of a pea. FSH was 80, and you can compare the testes to the right with a surgical peanut and see it's a really small testes. From this tiny testes, we had enough sperm for 3 cycles of ICSI, and the patient at 39 years went home with 2 babies over a period of 3 years. Now, the number of techniques that have been developed to retrieve sperm, the most dramatic being micro-TSA, where we cut open the testes, dissect the tissue, and try and find a good-looking tubule. And we feel very proud about it. But actually, this is a very crude technique. Imagine splitting open the testes, dissecting the parenchyma, digging around, often creating permanent hypogonadism, and still not finding sperm in more than half the men. And that is where we move towards the future. And there are many things that we need to do for men with non-obstructive azoospermia. We need to start by identifying the various genetic causes. We do only YQ microdeletion studies and karyotype, which is just the tip of the iceberg. There have been a large number of studies identifying more than 200 genes that could possibly be involved with non-obstructive azoospermia. The problem is that the frequency of these genetic individual single mutations is low, so we don't really know very often to what extent they are contributory. Some researchers have attempted to create a gene panel to try and identify genetic cause of NOA, but I think the main barrier is pulling together this vast amount of scattered knowledge, and The hope would be that in future, using AI to gather the data, analyze it, will enable us to create a map that will then make whole exome or genome screening a meaningful tool where in future I would expect that every azoospermic male with non-obstructive azoospermia would have a full genetic profile before proceeding further. And this would not only give us the cause, it would also help us predict whether he will have sperm. And that will also be linked with assessment of mRNA as measured in the seminal plasma. There have been many studies suggesting that a proteomic profile of the seminal plasma could predict which men would be having sperm loci within their testes. Again, the data is very scattered. It's not yet standard clinical practice, but I think it will be in future. So together with a genetic profile and a seminal profile, we'll be able to predict in which man or which men we would find sperm. Other attempts are also made to use a variety of other predictive investigative modalities. Now, another area where we expect to see advances is in how we look for tubules that contain sperm. This is how the testes would look at 25 times standard magnification. Many attempts have been made to use other modalities of visualization that might enable us to identify more viable tubules that could contain sperm. This was a very interesting attempt at using a fluorescent label to identify the tubule that needs to be picked up. But I think the real future is now, or coming now, with the newer technologies in microsurgery, where we can have vastly enlarged images, digitally enhanced 3D images, which will enable the identification of subtle differences in tubules. And once you add AI image recognition to this, all the surgeon will be doing is holding the spread open testes, the image will be analyzed, and an arrow will point out at the tubule to be picked up. I think it will enhance both the speed and the recovery rate. Finally, of course, the last bit, what do you do when there are no sperm in the testes? And I was actually waiting for Professor Anderson to tell us what he does, but his entire talk was on women, leaving me the scope to talk a little bit about the men. Now, this is more than 30 years since the first paper by Brinster spoke about injecting stem cells into the seminiferous tubules and showing spermatogenesis. And for 30 years, I feel like King Tantalus. It's coming, it's coming, it's coming, and we're still waiting for in vivo, in vitro production of sperm. Meanwhile, a huge amount of research has taken place. We know now that it's better to inject stem cells into the rated testes ultrasonically. In rats, it has been demonstrated that we can easily, not easily, but yes, we can achieve spermatogenesis. We've gone further from those whom we arrogantly call lower mammals to our cousins, the primates, and demonstrated that in vivo, we can also achieve spermatogenesis in them. We've stepped out into extracorporeal maturation of sperm. We've shown that these sperm can produce viable offspring across multiple generations. Even popular science has tom-tommed about this. Very interesting experiments combining in vivo and in vitro to achieve complete sperm production have been achieved. Again, this has been achieved in the primates, so the last barrier actually has already been crossed. And this was a very interesting suggestion made 8 years ago that perhaps we might even be able to add CRISPR editing of correcting a genetic defect and then restoring spermatogenesis. And here was a wonderful study published very recently where whole exome screening was used to identify a specific mutation in 3 men with non-obstructive azoospermia. Knockout mice were then generated and shown that they were infertile, and then the genetic defect was corrected again using electroporation to transmit a vector back into the cells, and spermatogenesis was restored. So most of the work has been done. So are we ready to see now management of non-obstructive azoospermia? Not yet. I think the first results will actually come from this group. because ethically, morally, socially, it is in the management of boys who have had their testicular tissue frozen in their prepubertal period. And this has been going on for more than 10 years now. And now we are getting ready to start seeing what we can do with this tissue. And Professor Anderson just mentioned 11 centers in Europe have been given permission to start using this frozen tissue. So I think the first breakthroughs are going to come from here. And it's a race. What will work? Are you going to inject testicular cells? Are you going to inject spermatogenic cells? Is it going to be in vitro? Is it going to be a xenotransplant? A whole range of options. But I think within the next 2 to 5 years, we're going to see a race to be the first and the most efficient. And once this succeeds, then the floodgates will open. I think the last barrier to utilizing this for non-obstructive azoospermia will be crossed. And then there'll be thousands and millions of men who are already waiting, many of whom have their wives' eggs already frozen, who would be ready for this therapy. So the future management is almost here. So to sum up then, the future of male infertility is bright. There's a lot to be done at multiple levels, from basic things like semen testing to advanced things like gene editing and regeneration of sperm. The final reminder is very simple, that the true future of male infertility is that every man should be able to father his genetic child naturally. And if not, then at least with some help, with all of us joining hands together. Thank you once again for the privilege of being here.